Hi, good morning. Before I start, can I ask how many of you are actually doing SWI as a routine clinical sequence? Very few in the audience? Yeah. So, we will go through quickly the physics of SWI. I will not bore you with a lot of physics and overview of the concepts of SWI because we need to know how it is actually different from conventional gradient echo sequences. And current clinical utility is an evolving sequence. You know that now new sequences of variants of SWI is coming up and the future direction. So SWI is basically a gradient echo sequence, but basically we were looking at only 2D gradient echo sequences which had a limited susceptibility contrast. So susceptibility weighted imaging as it stands today, it has got a magnitude phase and it's got a unique phase processing, and it is a three-dimensional sequence, so you can actually have very thin slices, and it is velocity compensated fully in all three orthogonal directions, including the slice selection direction, so you take away a lot of artifactual signals. And everybody knows that it is useful for detecting blood vessels, especially on the venous side, and mineralization and blood and calcium and so on. So this is an SWI sequence, and this is a 3D gradient echo sequence. I know that some of the other vendors also provide a 3D gradient echo sequence, and they claim that it is equivalent to SWI. But it may not be true. So although they have some other phase processing techniques which is enhance the susceptibility contrast. So this is a conventional gradient echo sequence. You can see that there is no venous contrast. This is the SWI sequence. You can actually see the veins, the transmedullary veins, which are even smaller than the voxel of imaging resolution could stand out. That is because of the unique phase processing. I will not go into the details. So if you look at only a 3D gradient sequence with venous bold effect, this is also due to bold effect. You can see these veins. You can see that these veins in the sulcal spaces can be seen, but the transmedullary veins and the very tiny veins which penetrate the deep gray matter is not seen. That could be seen only if you have a unique phase processing and SWI sequence. So what is this phase? Every MR image has got a magnitude and phase. So as radiologists, we look at only the magnitude image and the real and imaginary part of images. So if you have phase, you can have useful information. But why people were not using is that phase can actually produce a lot of errors. That means the phase incoherence can come and you don't get consistent phase averaging or phase results in order to have meaningful interpretation. What they have done in SWI is that actually a phase processing which is unique. They take away some of the extra field artifacts, like you have gradient field mapping, they have Hamming window filters to take away the susceptibility artifacts which are occurring in the blood, bone, or the brain air tissue or a bone air tissue interface. So after that, they uniquely process this the phase, so that phase gives you some unique information. Having said that, Avando is a left-handed MR system. That means the coil winding is actually towards the left side, and most of the MR systems in the world, I don't know about Skyra and IRA, I think they follow the same Avando system of coil winding. Most of the other systems, especially other vendors, you can see, even Siemens earlier versions of MR, they're right-handed systems. The coil winding is towards the right side. So if you know from the physics of Faraday's rules, you can see that if you change the winding direction, your polarity changes, and if your polarity changes, the magnet changes, your phase directions also will change. So that's what happened in this. In the Avando system, if you see that the blood products, which are paramagnetic, which can have a positive phase, compared to calcium, if it is diamagnetic, it will give a negative phase. Having said that, this is not true only based on paramagnetic or diamagnetic effects of substances. It's also depending on the geometry of the lesion. For example, this is almost a perfect sphere out there. This is actually a blood product, not calcium, because we see it as a positive phase. And you can see in the MIP images, the minimal intensity projection images, you can see that you can actually stack together these images to have a minimal intensity projection, just like you have maximal intensity projection in MR angiography and CT angiography. You can look at these veins and you can see the continuity of these veins. So we will go into the interpretation of this. Part of this talk is actually how you interpret phase. That is where you have maximum advantage compared to the other vendors. So these are the typical parameters. I will not go into the details of these parameters because it is all very important. The 20-degree flip angle is important to exaggerate the susceptibility effects, and 40 millisecond TE, which is quite high compared to a 48 millisecond TR, is also important because you want to suppress the tissue, you want to enhance the venous contrast. So we can have a fairly high resolution, and currently with the 3T you can have even higher resolution, and we use a pad factor of 2, and we can actually do this in 2.58 minutes. Basically we have actually traded off on resolution, and as a routine clinical sequence we have to compete with 2D gradient echo sequence, but as most of you are doing, as I've interacted, you're doing a high resolution, which we also do a 6-minute or a 7-minute sequence in case we have a very good case to show you. So it's a perfect marriage of phase and magnitude. You use a harming window filter in order to filter away the gradient fields, the inhomogeneities, and then the next step is phase mask, creation of a phase mask, which is the most unique technique. As radiologists, you are the cream of the society, you understand physics, that's why I have to go into a little bit of detail of this, though it may be slightly boring. So what is phase and this unimodal signal processing? It's a negative phase processing. We know that every single MR substance we image has got a phase information. Although we are not directly looking into the phase information, you can actually manipulate this phase contrast. So for example, the gray matter, the white matter, everything has got a positive phase information in SW sequence. What we do, everything which has got a positive phase information, we will actually scale them down to 1. So everything which is between 0 and plus pi, we will scale them down to 1 because we are not interested in looking at the gray matter or white matter or the differentiation. We are interested in actually increasing the susceptibility contrast. So everything which has got a negative phase value, we scale them up between 1 and 0. So that's what we do, and this is important. The TR and T is important in order to enhance these characteristics. If you still don't understand, this is not rocket science. This is how it does. So we have these positive guys out there. If you don't know who is this, he can just, he's not famous, but he's a positive guy, you can think. And then you have all the negative forces in the world. But in real time, what happens is that the media is actually stealing all the attention to these negative guys, and these positive guys won't get much attention. So this is exactly what is happening in SWA phase processing. We are interested in the veins, you are exaggerating these venous contrast. So that is why you get these veins, you don't have any gray-white differentiation, you're actually increasing the contrast of these venous structures. So more than that, after getting this phase mask, we multiply it with the magnitude image several times in order to get what you call an SWA image, in order to enhance the negativity within the lesion. So this is a classic paper from Yamada. It's on a conventional gradient echo sequence. You can see that the paramagnetic hematoma and calcification, which is diamagnetic, has got exactly opposite 180-degree phase difference, and based on that you can actually differentiate. This is, having said that, I again repeat, don't try to interpret your phases from all the lesions which you see. You can see this is a mineralizing microangiopathy in an Avanto system. You can see the magnitude image. This is a phase image. They are bright, they are black, but you can also look at the unaliased rim around this lesion. This is also important. As far as physics goes, I don't know exactly how it works, but when I speak to Hack, he has showed me a trick which I'll share with you. So if you have a perfect sphere-like or almost like a sphere-like thing, and in an Avanto system, which is a left-handed MR system, you see a black thing and you have complete unaliased ring or bright ring around it, you can be pretty sure that this is calcium, and this is proved to be calcium by looking at a CT. So coming to neurovascular applications in SWI, we know that Sturge-Weber and developmental venous anomalies, you can see these veins with exquisite contrast details using SWI. And SWI is also good in looking at familial cavernous hemangiomas. So please don't report cavernomas, because American Society says cavernoma should be avoided from your reports. It should be better called cavernous hemangiomas or cavernous angiomas, because cavernoma, it sounds to the patient more like a tumor. So this is a cavernoma, cavernous angioma, which is seen, large one, and you can see 2 or 3 in the conventional gradient echo sequence. If you do SWI with the higher resolution and the phase processing, you can see multitude of them. So it makes a difference to the surgical management of these patients who are having intractable epilepsies. Capillary telangiectasias also, whatever you could see on contrast enhanced MR imaging, you can actually see on SWA imaging. So the era of NSF, and we are moving slowly away from contrast enhanced images. At least some of the contrast applications can be done away with you doing SWA. I'm not I'm not here to say that SW is actually replace contrast enhanced MR imaging. So this is subarachnoid hemorrhage. We have done some studies on very hyperacute subaracute hemorrhage. You can see that blood as bright on CT even immediately after bleed, but we have compared some hyperacute subarachnoid hemorrhages because the oxyhemoglobin, the susceptibility effects are not very good, so we may still miss will miss a subarachnoid hemorrhage if you are doing only SWI. But this is a case if after few hours you can see subarachnoid hemorrhage as susceptibility signals within the sulcal spaces, which is again proved to be due to rupture of this MCA bifurcation aneurysm.